Dr. May, thank you so much for coming.
Thank you, David.
Okay.
Thank you for having me.
The first question's easy. Please state your full name and date of birth.
Well, I'm James Warren May Jr., and I was born on April 24th, 1943.
Okay. And the name of your parents, would you give us that?
Yeah, Jim and Martha. I was born in Lexington, Kentucky, and my sister and I grew up in Kentucky before going off to college and beyond.
Okay. Now, any medical association with your parents?
Not really. My dad was an engineer. My mother, a teacher of English, and they met at the University of Kentucky just before the Depression.
Ah.
And so it was some dark times during that time, but they were both teachers at the University of Kentucky, where they met.
And how many children, grandchildren?
I have two children.
Okay.
So Linda and I have a daughter, our first child, Allison, and a son, James, the second child. And we're blessed with 3 grandchildren so far. Allison has 2 children, and she lives in Mill Valley, California, and my son, James, one son, he and Kate live in Park City, Utah.
Okay, and what do they do?
Allison started out to be anything but a doctor, and after she tried, it sounds like a Winston Churchillism, after she tried everything she could think of, she decided to go to medical school and is now a practicing psychiatrist.
Wonderful.
At University of California, San Francisco, and she has a private practice as well.
Well, that's a nice place to visit.
It is I couldn't have picked places better for my children to live.
Yes.
So that I could visit, of course. My son is an economist and has several master's degrees and is interested in energy and has just sold his startup company that he and another fellow sort of co-championed about 10 years ago, and so he's unemployed, but he's looking for another job right now.
Well, good for him. We'll talk about that later
Yes.
off camera. I'm interested in that. Now, how did you meet your wife?
I met Linda at her engagement party. It's a slightly unusual story. It sounds hot and steamy, but it was really not that. I did meet her at her engagement party to a classmate of mine, a nice guy, good friend. I went to Northwestern Medical School, and they did not get married, but later I ran into her in Boston, where I was a trainee in surgery at Mass General and at Harvard, and we rekindled our acquaintance. I'm not sure she remembered me at all from the engagement party, but I definitely remembered her.
Wonderful. You never forgot her.
I didn't. Still haven't.
Okay, so you have to tell me what inspired you to go into plastic surgery.
Well, as a kid, growing up in somewhat rural Kentucky, we had a neighbor who was an internist. And he really took me under his wing. And for whatever reason, thought that I would be a good physician. I had been a fairly average student up until that time. And then I sort of caught fire and was guided by him to be interested in medicine. But it wasn't, David, really until I was an orderly and a scrub nurse at the Louisville Jewish Hospital working with Harold Kleinert.
Oh, famous Harold Kleinert.
Yeah, in the late 1950s, that I really caught on to a passion. And my first passion was an interest in anatomy, displayed anatomy, and then into hand surgery. And so as I went off from the University of Kentucky to Northwestern Medical School, I decided I wanted to be a hand surgeon. I didn't quite know how to get there, but I knew that I had seen Harold Kleinert, and I thought this would be something that I would really love to do.
You've seen momentous paradigm shifts and changes in plastic surgery during your career. Would you, in your words, just kind of, if you would expand on that a little bit, the pertinent things to you?
Right. Well, I think that plastic surgery as I knew it, as I selected it as the field that I wanted to pursue, treated many of the same disease entities that we treat today. But the technology has come a long way. And it usually is thought that a technology is spun from a knowledge of physiology. But sometimes it happens in reverse. And what I mean by that is when it became clear through the work of many of the giants in plastic surgery that you could put small blood vessels together without them clotting. And Harold Kleinert was one of the first, but of course Harry Bunke and some of the outstanding Chinese and Australian plastic surgeons. When it became clear that you can do that, all of a sudden it made it necessary for plastic surgeons to know the anatomy, neural and blood vessel wise, of a lot of different tissues. So here was a great example of a technologic breakthrough that then turned around and guided a specialty into a further study of something that hadn't really been of primary interest. Another example is the treatment of osteomyelitis. It used to be taught when I was a medical student that osteomyelitis was a terrible affliction. You couldn't be cured. You could,
except with an amputation.
you could endure it. It could be controlled every now and then, but basically not curable. And then with microsurgery, it became clear that you could do a much bigger debridement than we ever thought possible because you could fill the hole. And all of a sudden, this micro technique began to focus a new light on our understanding of pathophysiology. And all of a sudden it became clear that osteomyelitis, traumatic, was curable with an adequate debridement. So those are just two examples of a paradigm change in our field of plastic surgery. There are other technologic breakthroughs that come to mind. I didn't do a lot of maxillofacial or craniofacial surgery in my career, but a number of my outstanding colleagues at the MGH and across the country did. And some of the major understandings of how to stabilize the endofacial skeleton made huge differences in how we could deal with facial trauma. And then, of course, Tessier's work in doing cranial surgery was revolutionary. Other things that have more recently changed have to do with the treatment of skin. The surface that we have been dealing with and working with for all these years, all of a sudden we've learned how to dermabrate it, how to laser it, how to fill it up, how to lift it, etc. So those are just some of the milestones that come to my mind that are related to technologic breakthroughs.
Wonderful. Okay. And what do you feel has been the most important innovation in our specialty? Although I've got a feeling I know where you're going.
Well, I think, as the first thing I mentioned, microsurgery, I think changed the field because it changed our sphere of education. It changed the way we think about problem solving. I'll give you an example of what I mean, David, by that. One of my teachers, a surgeon that I respected a great deal, Ralph Millard. Dr. Millard, I was not a resident under him, but I had some interaction with Dr. Millard, and I was a student of his in the sense of me observing how he did things. And he and I had this discussion that basically led to this concept in my mind, which was new, and of course not to him. But he said, when you knock on a patient's exam room door for a brief period of time, pretend like you don't have a laundry list of techniques in your mind. Listen to the patient, win the patient, listen carefully and examine carefully what the problem is, and then logically deduce what the ideal treatment would be as though it had never been invented. Now, very often, that algorithm will take you to a procedure that you know exactly how to do. But if you force yourself to do that, very often you'll come up with things that are thinking out of the box. And I think Dr. Millard thought out of the box about as well as anybody I knew.
Any other mentors you want to discuss?
You know, I think it's a little hard to know how to define a mentor, and sometimes it's even best to define them in retrospect. Sometimes you don't quite realize you're being mentored.
Yes, oh, I agree.
At the time.
Yes.
Of course, the two people that were great life mentors for me were my parents. I was just fortunate, as was my sister, in having two people that demonstrated unconditional love and support, and they were happy to support me no matter what I wanted to do. But from a surgical point of view, I would be remiss if I didn't add John Constable to the mentor list, a wonderful plastic surgeon who's still living, alive and well, and enjoying his summers not too far from where Linda and I now live on the coast of Maine. Richard Smith was another one who was an incredibly gifted teacher, and a lot of the teaching patterns that I have used are shamelessly borrowed from him.
I wouldn't say shamelessly, but it's all for the benefit of the patient. So.
And the students.
Yes.
Right.
So what do you feel your greatest professional accomplishment is?
Well, that's a very easy question to answer. I think all of us as plastic surgeons have days when we go home and we think we've done nothing quite right, and other days where we have one or two things that we thought we did better than others.
Sure.
But the overriding thing to me was the privilege that I enjoyed in being at a place like the Mass General that attracted some of the best and brightest students that a teacher could ever hope to work with. And the same was true for the attending staff that I worked with, not only in plastic surgery, but in many, many other fields. Okay. And the Mass General also attracted a remarkable crossroad for patients. It was just a wonderful place to be for a person like me.
Yeah, yeah. Well, of course, name speaks for itself, doesn't it? What do you feel, sometimes a tough question, a lot of people answer different ways, but your greatest professional disappointment?
Well, I think as a resident, when you go off a rotation, you like to leave it in better shape than when you took it.
Okay.
And you develop a certain degree of self-pride in that. You've passed the baton having run a fast lap,
yes,
and you haven't fallen down, and you haven't stumbled out of the box. And I feel sadly, in some ways, that the field of plastic surgery and in general the field of medicine isn't as autonomous as it was when I came into the field. I think professionalism has slipped. I'm not sure that we as doctors could have totally controlled it. I think it was more a direction of our society. But you know, there was a day when doctors called the shots, and more now we're called providers.
Yes.
And the patients are called customers. And we fall into this hospitalist syndrome. I'm sure as I bow out, if I'm able to get to a hospital, I'll be treated by hospitalists and by no one that has ever met me before.
Right.
I'm sad about that. Is it a sadness that is justified? In one way, yes, but perhaps in another way, no. Maybe it was just a fait accompli. But I'm sad about that, because I think the professionalism of the more senior people in medicine nowadays is almost by definition different than the younger people coming in. David, there's one other thing that I'm disappointed in, and I would be remiss if I didn't mention this. I think we're all aware as plastic surgeons that we have an unusual, almost eclectic mix within our field of aesthetic surgery and reconstructive surgery.
Yes.
And hopefully residents are taught to do both types of surgery well and to manage the patients well. But as time has gone on, our society seems to value and to be willing to pay more for cosmetic surgery
Yes.
than reconstructive surgery.
Yes.
And it's almost made reconstructive surgery a little bit of a second-class citizen.
Red-headed stepchild.
Exactly. And I'm sad about that because I think to be a good aesthetic surgeon, it is very helpful to be a good reconstructive surgeon.
Oh, yeah.
And there's no question to be a good skilled reconstructive surgeon, it's very helpful to be a good aesthetic surgeon. But I think this disparity in these two roughly divided types of plastic surgery adds more problem to being a plastic surgeon today than it did when I started.
So who would you say that you admire most professionally or personally?
Well, you know, the correct answer to that question, of course, is your wife. Don't aspirate that water. But in my case, it's really true. Back when I started in training, I was addicted to plastic surgery. I loved everything about it. I spent too much time away from my family. I knew it at the time, and I know it now. And if it hadn't been for my wife, as acting almost as a single parent, our family would not have turned out the way it has. And I am incredibly indebted to her for that. And so I would say that of all the people that I have come across, I admire her the most.
Would you give us some words of wisdom for present and future generations of plastic surgeons?
Oh my goodness. Well, I think present and future plastic surgeons, I would say enjoy what you do. I can't imagine not enjoying what you do if they've chosen the right field for them. I think it's important for us to share with other specialties. Mm-hmm. And what I mean by that is turf wars go on, and I was involved in a few during my career. But if you take the high road and you educate your patients and educate your own colleagues as to what you're doing and how best to do it, then plastic surgery as a field will always be looked up to.
Yes.
And I think that keeps the spirit of innovation alive and well. I think we have innovated extraordinarily well, and the quality and the caliber of trainee that we're bringing into the field currently has never been higher.
Yes.
And there's no reason, if we keep our eye on the ball, to be leaders, innovators, and educators, that the future of plastic surgery should not remain very positive.
Okay. Now, the little bit of the segue is, what do you think as a society, as a specialty, our greatest mistake has been?
Well, there are a number of things that I think we could have done better. I don't know whether I necessarily, in thinking off the top of my head, would rank them in a particular order. I think one thing would be to carry on with what I just mentioned, and that is, rather than fight with other specialties, I think that we should lead by example, by innovation, by teaching. But David, I'll add one other word, and that is availability. Mm-hmm. You and I both know that there are patients that end up needing care, whether it's a financial disadvantage that the patient has no insurance, or whether the patient ends up in a hospital in the middle of the night. We as a specialty need to continue to focus our energy and efforts on availability. If we have all of those other attributes, which we do have, and we're not available, they're for naught.
Right.
So we need to be available. There's another mistake that I think we've made that is not so much related to plastic surgery only, although I think we're guilty, but it has to do with the educational board system format that we all go through. The American Board of Medical Specialties has 24 boards, as you know, and one of them is plastic surgery.
Right.
And yet, patients never know that. and I mean almost never. And they don't know what the ACGME is. They have no idea of what a field like legitimate plastic surgeons go through to examine the surgeons that will have the seal of approval of the American Board of Plastic Surgery, to be a diplomat of the American Board. And part of that is our fault. We haven't educated the public as to what's important in giving your own doctor a checkup. Shame on us.
Yeah.
I think we've done an incredibly good job of making the board system work,
Right.
and make it a wonderful protection system for the American public. What we haven't done is to tell the public that, because they have no idea that there are many plastic surgeons around the country that volunteer 2 or 3 or 4 days a year to give the board exam. They have no idea that you can become a board certified doctor, call yourself a plastic surgeon without ever having done a residency, and on and on and on. We've not been good educators for the public.
What words of retirement? This is something I deal with. I'm not retired yet, but just for future plastic surgeons, how you feel about that, what you've done as you've adjusted your life.
An observation that I have made as I approach retirement, I've been retired now for 3 years, and I would define retirement as treating patients.
Right.
I'm really not retired from plastic surgery. I'll explain that in a minute. But one of the observations that I made was that each of us in college and in medical school are goal-oriented, to do the right thing, study hard, pass higher exams, move to the next notch. Mm-hmm. And this is all related to perseverance and hard work and maybe a little talent. Ultimately, we get into residency and we do the very same thing all over again so that we can have the opportunity to choose a specialty that is quite popular, plastic surgery. And so it's surprising to me that plastic surgeons who are practicing don't immediately glom onto the concept that retirement is going to require work, mm-hmm. persistence,
yes. focus,
and I would add another quality, and that is introspective understanding of oneself. And what I mean by that is, when you retire, you're going to be replacing some of the things in your life as a plastic surgeon that made you happy. It's not the same, certainly for everyone. Some of the qualities are similar. You're going to need to figure out, how do I replicate that experience when I'm not taking care of patients and not operating? And it can cover a wide range of things. But the introspective analysis of what that is that makes you happy is something that many of us have never really done. And people that don't feel they're prepared to retire perhaps haven't done that enough. And once you've done it, and once you know what the qualities are that you're trying to replace, then you can start to replace them before you retire. So, in a simple word, I'd say preparation and then soft landing. Meaning, don't cold turkey and then say, okay, today I'm retired, I'm going to start to prepare. That isn't the time you do it.
So I would ask you then what your predictions are for the next 25 years or quarter century in plastic surgery. Then I would like to get to these items that you brought.
Oh, sure. Well, I'm very bullish on plastic surgery. I used to give a little talk to the medical students at Harvard called The Power of Plastic Surgery. And I'm envious in many ways of youth. But I'm particularly envious of the residents in plastic surgery right now. Because, David, they have more power to treat patients
yes.
than I did when I started.
Yes.
And so in the next 25 years, incrementally as time goes forward, I'm sure the field will look quite different than it does today. We'll probably treat the same entities,
okay.
but perhaps treat them with greater power greater efficiency, greater outcomes for the patients. So I'm very bullish on plastic surgery. But I would say that I'm particularly positive about plastic surgery if we continue to innovate, to share, and to teach.
Wonderful. Okay, so you brought us some items.
Well, I was asked when I came to this little interview to scrounge around and see what I had that maybe some of the folks watching this in the future might just find interesting. So I mentioned that microsurgery came on the scene, and it happened when I was a resident. And that's why I said the learning curve was like this. You'd open the journal every day and find a different tissue transfer to do that you didn't know existed. And this is the first pair of loops, optical magnification, that I ever had. Ultimately, I would use these to dissect out vessels in a recipient site while somebody else dissected out the donor vessels, or vice versa. Very often in a replant, we would use these, I would use these to dissect out the recipient vessels, while the smaller damaged vessels in the digit that had been amputated or whatever were being dissected. Another item that I brought is this Watson knife. One of my very first recollections as an intern, it wasn't the first operation I ever did, but it was in the first several weeks. Dr. Brad Cannon, who was the senior surgeon at our hospital and a national leader in plastic surgery, helped me do a skin graft. And he started me out with this instrument, a Watson knife, and it has an adjustable blade holder. I didn't bring the blade, but the blade's put in here, and then this little gizmo arranges the thickness of the skin graft that you take. I took one graft with this, and then he used an instrument that looked just like this with a free blade to show me that it could be done free-handed as well. I think his graft was better than mine. But this is a very useful instrument to have because you can put it in your black bag and you can travel with it. And you can render skin graft services to an underserved community without a fancy power-driven dermatome. The final thing that I brought was just an article. It was published in 1963. But I thought you and maybe the audience would find this interesting. I had given a little talk to a group of surgeons in New England. And it was a small audience, as most of my audiences were. And at the end of the talk on replantation, a senior surgeon stood up and came up to the podium. And he put out his hand and he said, "Dr. May, I just wanted to thank you for your talk. And my name is Robert Shaw." And the name rang a bell from the Mass General, but I wasn't quite sure why. He said, "I used to be a vascular surgeon at the MGH before you were ever an intern there. But I'd like to send you an article that I wrote, and I wanted to read this because I'm not sure that our cameras could pick up the title. The title of the chapter, really, it was a paper, was The Treatment of the Extremity Suffering Near or Total Severance with Special Consideration of the Vascular Problem." Robert Shaw was a very well-respected vascular surgeon at the MGH well before my time. But he happened to be available in 1962 when Ronald Malt, who was the chief resident in general surgery, had a patient arrive who had had his arm amputated. That patient was the world's first human replant. And Robert Shaw was the doctor who did the vessel repairs that made the whole thing work.
Fantastic.
But one other interesting aspect of Robert Shaw, he was a very colorful man, and as I said, hugely respected. Apparently in the Korean War, he had set up a group of units that provided surgery in the battlefield called MASH units. And his nickname was Hawkeye, Hawkshaw. And I think he was the person in the MASH unit idea was what MASH.
Robert Altman was the writer, I believe, of the series.
I think so, and Alan Alda was the person who was Hawkshaw.
Yeah.
Right. So I just thought you'd be interested in that.
And I think that's a perfect ending to this interview. Thank you so
Thank you.
much, Jim. What a pleasure and
My pleasure.
privilege and honor. Thank
My
you
pleasure.
so much.
Thank you.